I2S2 session, co-organized by the Center for Biomedical Informatics, the Department of Psychiatry and Behavior, Implementation Science Corps, the Rhode Island Quality Institute, and overall coordination support from the Advanced CTR program. Today, it's my pleasure to introduce Dr. Jonathan Leviss, who is currently the physician site lead at Providence Community Health Centers, Prairie Avenue. He's also on the faculty at Brown University. Dr. Leviss is an accomplished chief medical officer, chief medical information officer, an academic researcher, and a consultant. In all his roles, he has a broad range of experiences and expertise that we'll be learning about his insights. First, from his perspectives as a CMIO at New York City Health and Hospitals, where he led the EHR implementation before meaningful use was a thing. And then at Sentillion, he introduced single sign-on and identity management before that was a thing. And then at the Rhode Island Quality Institute, he expanded CurrentCare, which was before HIEs were a thing across the country. And then at AMC, he grew one of the largest patient remote monitoring programs in the United States before that was a thing. And so overall, Dr. Leviss has provided clinical informatics expertise to small startups, Fortune 50 companies. He's very well known in the area of health information technology and what works and, well, what doesn't work. Perhaps most known for editing Hit or Miss, the American Medical Informatics Association and Health Information Management Society's co-published book on health and information technology failures. He's practiced in a range of states and is board certified both in internal medicine as well as in the subspecialty of clinical informatics. It's my pleasure to welcome Dr. Leviss today, and I will let him get started.
Okay, Neil, thank you very much. Let me see if we can advance this. Okay, yeah, so from one perspective, having done lots of things, I guess, as Neil said, before they were a thing, I've learned about, with many colleagues, I should say, we have learned about what sometimes causes things not to work, and also sometimes what helps things work. Everyone hates the EHR seems to be a common theme and a common discussion. I will say I'm still a fan, my own conflicts of interest, as Neil mentions, aside. But I also believe that we can fix this. It's just about how, and a lot of it is about why. So in advance of this presentation, actually, the crew at Brown put out some feelers to get some questions, and some of the questions that at least some of you shared that I thought would be important to discuss were, first of all, what made everyone start hating their EHRs, or do people really hate their EHRs? And were there some contributing factors? What's the potential impact of integrating some new technologies, apps, using some standards? Could this help patients? Could this help providers, care teams? Why did informatics get put aside in the EHR development and implementation process? An interesting question or observation. Certainly need to touch on that one. And where does physician burnout fit in as we solve our EHR-related crisis? And I know that you're all muted. We have asked, the chat is open, so Neil's going to continue to monitor the chat and will interrupt as needed, as he sees fit, to keep me on track and to answer your questions. So I will try and touch on some of these, and please continue to ask others as we go. I wanted to start with a little bit of a historical perspective. And given that this whole process around healthcare IT and EHRs has been a little surreal, I think cartoons would actually be more helpful than imagery. So from a historical perspective, many of us in healthcare, I'm 52, I've been involved in healthcare for over 30 years at this point, including medical school in earlier days. We remember patients coming in and just not having the information about the patients. Today it happens sometimes, but literally, what is the patient's diagnosis? What's their past medical history? Do they take medications? What medications do they take? It obviously hampered the care we could give. Where's the x-ray? We see something abnormal. Is it new? Is it old? You know, the joke, and I say that from a sense of Black humor, not happy joke. At 2 in the morning in an ER, when a patient came in who couldn't give a history, it was the easiest patient to work up because you didn't have any information. You'd examine them, you'd do tests, you'd treat empirically. You didn't feel particularly good about it. That part wasn't easy. And we all knew the struggle of where's the chart. And sometimes it was even our patients who we had seen before, who we knew we had this information in the chart, but it just wasn't there when we needed it. At other places, there were experiments with EHRs. There were a bunch in Boston, Mass General, Brigham and Women's, out in Utah, Latter-day Saints, the VA, where I trained at NYU, down in Tennessee at Vanderbilt. There were some early projects, some dating as far back as the 60s, but certainly some robust efforts by the early to mid 90s that when being studied, were even showing it's not just about getting the medications to make them available so that we could look up on an application on a computer and know what medications a patient's taking. It was not just that now we actually had the lab results that were ordered a month ago instead of having the patient sitting in front of us and wondering what was the lab results from a month ago. We knew when patients' allergies were. We actually could integrate all this data together. And there were studies that showed that it improved quality, it improved outcomes, it prevented adverse events. Now, the interesting thing is all these studies were being done at the same sites that for the most part had built their own systems. And in hindsight, and even by the early 2000s, there was a lot of criticism of that. These were not independent audit groups. And in the early 90s, as some of the leaders at these organizations that had built their own systems and assessed them and shown the benefit, went on to become involved in some of the major quality and safety organizations in healthcare in the US. And so the reason that that's important is the word started getting out to even organizations like Joint Commission and some of the safety groups, that there actually was a different way, that we could start to leverage technology. And again, this is the 90s, right? This is the age of the internet. This is the age of computerized banks and other industries. Then what happened? Then we got this huge study in 2000, in the year 2000, by the Institute of Medicine, to Error is Human. And that really changed the conversation because they studied medical errors in all kinds of areas in healthcare. And the estimate, and by medical errors, they included patients getting the wrong medication, a wrong dose, maybe not the dose that the doctor prescribed, or a medication to which they were allergic, or a medication that interacted with another medication they were taking that caused a major problem, or actually not having the lab data to know what resistant bacteria the patient had or what they had last month, or to know what their kidney function was when they're getting a new medication, all different things. Many of the errors were data related, meaning not having the right information at the right time to treat the patient. But in the end, the IOM said, we're probably killing about 98,000 people a year in the United States from medical errors. Some of the estimates were close to 200,000 a year, but bottom line is it was a lot. And this grabbed a lot of attention because obviously the IOM is filled with smart people. One of the analogies was that that's the equivalent of a jumbo jet crashing every single day. And so part of the discussion that this raised was if we actually had a jumbo jet crashing every day, we'd all be talking about it. We'd all be raising a stink. We'd say this is unacceptable. So we've got these different things going on with this major attention to these problems. And within the next couple of years, then I should say, I'm giving highlights. There obviously were a lot more factors that led to all this, but I think these highlights are representative of what moved us towards electronic health records. By the fall of 2004, Blue Cross Blue Shield in Massachusetts, and I think they were either criticized or possibly even under investigation for having revenue that greatly exceeded their costs. And so they decided to spend $50 million on a not-for-profit effort to fund the implementation of EHRs in 3 pilot communities in Massachusetts. Again, they're looking at all the data points. We're all recognizing that it's bad when patients show up and we don't know what's happening and we don't understand their care because we don't have the information, because we can't find the paper chart. There were enough places that had showed that there was real value of doing this. And at this point, probably 1, 2, 3% of the health systems in the US were using advanced technologies in EHRs, what we called EHRs in those days, different level of functionality than today. IOM had raised attention. Blue Cross Blue Shield had to spend some money. They decided to try and do it in a way that would be of a community benefit by funding 3 projects. One was roughly Newburyport, Massachusetts, Brockton, and one was out in the Berkshires. I'm blanking the third name, but it was out in the Pioneer Valley. It may have been North Adams or somewhere around there. And the idea was 3 very different communities in Massachusetts, and that they, with this $50 million, they would fund the implementation of EHRs for ambulatory care providers so that they would be able to achieve and overcome all these issues, and that they could communicate with each other as a community to improve everybody's health in the entire community. It's an interesting notion. Fast forward a couple of years, 2008, what happened? Right? We have the Great Recession. Economy tanks. Obama gets elected. We have the American Reconstruction Reinvestment Act, I think it was, the otherwise known as the Obama Economic Stimulus Plan, or ARA. And one of the governing concepts for all the dollars that were spent on ARA were shovel-ready projects, because the idea was federal government was going to spend this $600 billion, which at the time was seen to be pretty big. Again, this is pre-COVID-19, and part of the Biden administration's learnings was it may not have been a lot of money, the $600 billion, but of that, it was to invest it in projects that could start immediately. So guess what? Representative Kennedy, Senator Clinton, and others already had drawn up this program called the HITECH Act to invest in EHRs to help what Blue Cross Blue Shield had helped do in Massachusetts, to help community providers, but also to help hospitals start to implement and implement quickly these technologies that, as far back in the 90s, were seen as pretty good things that they would help. Now, HITECH, as part of ARA, did this to the tune of $32 billion. That was seen as a massive moonshot. In fact, prior to that, the US government had never spent that much money on any single endeavor, on any single project. And so we all thought this was going to be a good thing. So what came next? Meaningful use. A lot of EHR funding in that $32 billion. There's a question on, was it actually enough? We'll talk about that later. And lots and lots and lots and lots of EHR implementations all across the country, in part because the whole idea of the shovel-ready projects were to get the money into the economy ASAP. So there was a timeline. You actually had to start, and practices had to start and had to move to take advantage of these funds. And so from, at this point, 10 to 15 years, all the discussion of the value of these, so people are aware of EHRs, this was seen as the opportunity to take advantage of federal government funding rather than providers and organizations paying for it themselves. Now, a lot of other things came along with that. Through the Meaningful Use program itself, the federal government tried to act like a good investor and say, we're not just going to write you a check, we actually want to measure and hold you accountable to outcomes. And the payers, the insurance companies, started to get involved in it also. And we developed all kinds of new quality reporting as practices, large and small, whether it was a large place like 5, 10, 20,000 or more provider organization like New York City Health and Hospitals or Kaiser Permanente or the VA, or a 5-doc private practice, or a place like Providence Community Health Center that might have 60 to 100 providers. We all started having to provide quality reports that were in much greater detail. And for most organizations in healthcare, that was new. The idea that we could look at all of a provider's patient panel and have some outcomes, whether that was lab values to see if their diabetes or cholesterol is on target, whether to see if patients got readmitted to the hospital, lots of data. It also allowed, and I should add, that was pretty new for healthcare. There have been quality metrics programs for a long time, but not to the breadth of a practices or a hospital's patients, and not to the depth of the data. Because when it was on paper, it was a lot harder to get to those things. There also was a lot more easier reinforcement of E&M coding, of the billing requirements. And meaningful use also required us to track lots of different things. So lots of et cetera is going on in here. This all came very quickly. something very important to keep in mind. I'm going to add some additional context to all of this. And the goal is by the end of this, you're all going to understand why people are saying they hate the EHRs, I think, as well as everybody else does. 1998, Bill Stead, who was one of the major pioneers in this field down at Vanderbilt, a physician, noted that real wins happen when a medical informatician has the skills and authority to use the system, to identify what is needed, to make the necessary operational changes on the fly, and to redirect the research effort. It's a pretty big deal. David Klassen, who was one of the leaders in the development and evaluation of the early systems out in Latter-day Saints out in Utah, and became a major leader and still is expert in the field. In an interview in the New York Times, noted that CPOE, which was the acronym for computerized physician order entry, one of the key features of EHRs, instead of doctors and other providers writing orders by paper, entering it through a computer, that CPOE is the first IT project not being led by IT. Now, when David had said that to New York Times, I actually was a CMIO in New York City, and I looked at it, and my first thought was, that's a population bias assessment. Because what we had seen at that point, and what we continued to see over the next couple of years, were there were actually lots of CPOE projects that were being led by IT, that were not being led by physicians and nurses and pharmacists. But none of them succeeded. And so David's observation needs a little modification. It's actually that successful CPOE efforts were really the first IT projects in healthcare that were not led by IT. Still, massive sea change in how we're doing things in healthcare. Hirsch and Wright interpreted part of this. So Bill Hirsch, who's the chair of biomedical informatics out at Oregon Health Sciences, and also major leader in the field, and one of his fellows, who's now faculty and partner at Harvard Medical School, also, I think he's still at the Mass General, Adam Wright, did a paper where they said, all right, in 2008, if the US is going to go forward and fund this massive EHR implementation across the country, they looked at the number of health IT professionals that were at that time working at hospitals that had done the early implementations. And that was only about 20 to 30%. And they recognized that some of them might not be needed at their core organizations anymore, but they identified that we had a delta, we had a gap of 50,000 more people who were going to be needed if we were going to do this rollout, if we were going to implement EHRs across all the health systems. Where were those people going to come from? Now, Bill Hirsch actually was one of the crew who put together some of the training programs and courses that were distributed to community colleges across the country, also funded by ARA. The idea to begin to create introductory skill level on informatics and on IT for healthcare workers, for docs and nurses, for staff. But as Vic Ketterpal, who was the first, and I think he was the first, he certainly was the last chief medical officer at GE Healthcare who wore a ponytail, which may reflect as much on him as on GE. Vic commented once in 2002 that just because someone learns to write poetry, and I'm modernizing his statement, but doesn't mean they can create an Amanda Gorman level poem. And I think it's really important to realize that. We'll talk a little bit how that plays out later. Also, along this time, as per David Klassen's observation, there were these new people who were becoming involved, leading efforts in healthcare. So Rich Kremsdorf and I did a study on health systems that had been successful with their HIT implementations, in particular CPOE, looking at this new model, this new role of the CMIO. Gartner started to look into CMIOs also. So we've got all this stuff going on in organizations just as we're beginning to take this on. So what happened? This book was not supposed to be published. The whole idea of hit or miss is because we ran into a lot of oops. Back in, even before high-tech funding, in 2007, there was a group about 10 to 15 of us and one of the academic subdivisions of the American Medical Informatics Association's AMIA. We were trying to come up with a clinical informatics group, clinical information systems work group, trying to come up with an activity for our annual business group at the annual conference. And may have been Gil Cooper, and someone suggested, hey, instead of talking about all our successes, what if we were to do an open mic session and talk about our failures? Like, wouldn't that be funny? And it was sort of in the Breakfast Club, Judd Nelson perspective of it'd be social, sad, demented, but social. But we all thought this would be a great idea. So we put a call out for the business meeting, asking people to bring stories of their projects that had failed to the annual AMIA conference. And AMIA, for those of you who are on this who don't know, AMIA is the American Medical Informatics Association. It's the main academic organization that studies medical informatics. And we did this open mic session. And one rule was you had to de-identify anything. You couldn't disclose the organization, the names, the brands, anything. The idea was just tell the story, just help everybody laugh. After 40 minutes of people sharing stories, there's a line going down the edge of the auditorium with more people wanting to share stories. We've got about 100 people in the business group meeting. We had to stop it to move on to the business group, but we realized that actually the stories that were being told that initially were set up as tongue-in-cheek, and we're all chuckling a little bit about the big problems and disasters we all face, actually were really useful learning experiences for all of us. And part of what we realized was that we hadn't been sharing them, that we were so caught up in sharing our successes that we hadn't been sharing our failures. And so we got together again, the original 10 to 15, and said, you know what, let's actually collect these cases. Let's study them formally and let's publish them, because we have to learn from our failures. And being academics, we put together an academic model and realized that there's actually a science of social science of learning from failures. And we use that as the methodology for the book and the cases, which now it's in its 3rd edition. It's sold a couple thousand chapters, a couple thousand books. It's had at least 60 contributors, because we realized that there's still a lot we need to be doing better. Not as easy as we thought it was going to be. It highlights what Rob Kling first introduced, or if he didn't first introduce, he certainly gave it the most early attention. Kling is really known as the father of social informatics. And social informatics refers to the study of the social aspects of computerization, including the role of information technology in social and organizational change, the use of IT in social contexts, and the way that social organizations of information technology are influenced by forces and practices. At the end of the day, part of what Kling advocates and what perspective we took in Hit or Miss is these EHRs are not technology projects. They're not technology projects that we're doing for the sake of the technology. They're not technology projects in healthcare. They're not technology projects in healthcare organizations. They're actually healthcare projects that use technology. And like any other healthcare project, they involve people, they involve processes, and they do involve technologies. Absolutely. The idea, getting back to what we learned in the 90s, the idea is that we can use these technologies to do things in healthcare and medicine in ways that we just could not achieve and address in paper. And today, I think even the strongest critics of the EHRs, the people who really hate their EHR, recognize that it's not about going back to paper. But it's really important to realize that the people and process component, the organizational issues about implementing these technologies, are actually even more important than the technologies themselves. And that's what Bill Stead was getting at. That's what David Klassen was referring. That's what Rich Kremsdorf and I found in our papers. That's what, again, what Adam Wright and Bill Hirsch were talking about. All right, if there's a people and process, and even about the technology, what do we do if we don't have enough people? If we don't have enough skilled people to do this correctly? Well, I think we all know what happens, because you asked questions about it that were spot on. And I thought I modified some of the comments and grouped them together because I thought you raised really interesting things. Did everyone start hating the EHRs when the commercial EHRs came out? or was some of it when the homegrown EHRs were coming out? So again, the really positive interest and assessed impact of the early EHRs were homegrown. We didn't really start to get the availability of the commercial ones that were being widely deployed, until 2000, even a little bit later. And that's really important because it meant that the people who were using these systems were building their own systems, right? And that meant that they actually had a pride and a commitment to make them work because they were their own, or they're their colleagues, or they were designed to solve the exact problems that worked in those or in their own organizations. Now, don't get me wrong. I've had enough colleagues who trained at the Brigham and Mass General who talk about clicking enter on a medication order and counting to 30 before it got processed. So some of the same problems that many sites have today with their EHRs that people routinely talk about hating. And whether hate's the right word, or I would at least say recognize that that's just a silly degree of technology function today and should not be tolerated. Some of that was around then also. But yeah, a lot of the homegrown piece provided a pride of ownership, but also catering to solve the key problems that you had to solve. That's different than building a commercial system that's going to be mass marketed, that needs to generate a profit in its sales, and needs to try and fit everyone, and needs to cater to all the other pieces that showed up and forces that really got amplified with these EHRs. Quality reporting, making sure that we're capturing all the data that a payer or that the federal government or that someone else wants us to capture. Making sure that we've checked all the boxes for the billing regs. So a lot of the commercial EHRs had to address all of those needs. Homegrown's local organization could decide whether or not it needed to. The other reality was the homegrown EHRs were also rolled out in academic medical centers. And we've seen a lot of literature on the fact that when you have medical students and health staff around, it was a lot easier to implement these systems. The whole idea of the Blue Cross Blue Shield pilot in Massachusetts, the idea that Western Mass and Southern Mass, south of Boston and northern of Boston were three very different areas to do a pilot for an EHRs, has also raised other questions. It's all Massachusetts, right? It's all the Northeast. Do any of those communities actually apply to what's going on in Iowa or Texas? And they only did it for about 1,000 to 2,000 doctors. So that core project became a huge base for how we scaled this national rollout of EHRs the federal government funded. In fact, even the dollar amounts, meaningful use essentially made about $50,000 available per provider to fund their EHR rollout. The Blue Cross Blue Shield investment was somewhere between $25,000 and $40,000. And there's a reason that those numbers are similar. The Blue Cross Blue Shield project was really the only reference place upon which to base the national incentive payment, which is why the notion of was it even the right amount? We don't know. But so really important to recognize that we did a lot of changes really quickly to get these EHRs out into the community. Question of too many EHR tests for physicians. A lot of what we did was, and I'm going to use we because it was pretty global across the country, we had the opportunity to create tasks for physicians to do because you could tee it right up into their workflow. Now, we've been talking for at least as long as I've been involved in healthcare redesign, so almost 30 years at this point, about the idea of keeping everyone working at the top of their license, top of their skill set, which means tasks that don't need to be done by a physician should not be done by a physician. Tasks that don't need to be done by a nurse should not be done by a nurse. And if you don't have enough medical assistants or other staff to do a task that they're capable of doing, rather than escalating those tasks to the more expensive people, you hire more medical assistants, right? It's a basic efficiency leverage model that we see happens across industry. We're not doing it in healthcare. Organizations that are have higher satisfaction among their providers and among their nurses actually are. But that is, by some estimates, in the 20 to 30%. Others have used the EHR as an opportunity to require more tasks of physicians than they ever had before. And it's been pretty obvious. One recent comment by one of the CMIOs at top 15 largest health systems in the US said, literally 3 weeks ago on a listserv, docs are free. If we need something done, we can just ask them to do it. Wasn't his suggestion it's a good idea, but if you hire staff to do things, the organization will say that costs money. And that's a lot of what has happened. That's why it's so important to recognize, back to Kling's point, and this triangle about people, process, and technology, and all these other things that were going on as we were rolling out EHRs. We made a lot of decisions that cause a lot of workflow problems, right? We made people, process, and technology decisions that in hindsight, maybe we shouldn't have made. Now, part of the reason we may have made them is because we didn't know, either because the people implementing them were newbies, they were part of the new 50,000 who got trained, or the model on which the rollout was based was, like in the case of Massachusetts, or these small, these academic health systems didn't apply to the rest of the places. And no one slowed down. We kept going ahead. Another key example is this issue of structured data, because the answer has been in EHRs to structure all the data for everything to make it easier to report. I'm going to keep going, and we're going to talk about where we can go from some of these things. Simple question about integrating apps on the EHRs and the EHR data and patients. Can some of these things even be used to address some of the questions and concerns in the top group? Part of the challenge we've had in EHRs is because they become these behemoth projects with complexities across the organization, with technical complexities, and with the reality that it is difficult to access their data, is it stunted a lot of the innovation. And we're starting to see some of these things. And there's a lot of belief that adding apps and adding simple add-on technologies is going to help make physicians' lives easier and healthcare organizations easier. And it may not even affect the reporting that we need, which does require some structured data on some end. But I think it's a good question. I think the jury's out. We're going to have to see what happens. But and we'll bring that up again. Let me just move on, because all of this is related to why did informatics get put aside in the EHR development process? And I want to be clear, it wasn't. But it was at a lot of places, and maybe even wasn't most. And this gets back to Bill Stead's comment. This gets back to David Klassen's. This gets back to what Rich and I found with the CMIOs. The organizations that are struggling less with these areas, Kaiser, VA, before their funding started getting dramatically cut in this area, which actually is about 15 years ago at this point, we saw very different things, which is why I think that this is one of the key questions on how do we get back to this, and how do we grow the expertise, and recognizing, as David Klassen pointed out too, that this is a huge sea change in the power dynamic in healthcare. Right now, there's a lot published on the fact that the leading healthcare organizations in the US, by quality, by efficiency, by patient satisfaction, by staff satisfaction, are actually led by physicians, and also have senior nursing leadership that is part of the upper echelon of management. But that's not all of them. We know that's not all of them. That's part of the opportunity, because this is, again, where we're talking about these projects are not technology projects. Just like running a health system is not an organizational, it's not a healthcare project, it's an organizational project that lives in healthcare, which means we have to understand the healthcare. We have to understand the healthcare informatics, and we have to make those decisions drive all of these issues that are identified in these questions if we're going to address them. This takes us right into burnout. And I continue to question the use of the term, because I think that The idea of burnout also recognizes that when you started, you may have been happy and enjoyed what you were doing, and it became worse. I think that most providers and nurses and other staff in healthcare, but we're talking about physician. The question was about physician burnout. If they had actually understood what they would be doing when they started, they might not have started. They might not have wanted to do it in the first place. And the use of the term burnout brings up a notion also of the physicians owning some of this. And again, this is organizational. So let me raise the why. And this is also contextual in society. But it's important that we address it. Okay. So before you read down to it's not a new thing, let's just recognize that the IHI identified their 4 pillars, right? The idea of improving health populations, enhancing the experience of care for individuals, reducing costs. That was the triple aim. They finally added the 4th aim, that the current phrase they use is attaining joy in work, but recognizing that the staff were important, and how the staff and the providers and nurses feel about what they do is important. When they made this big announcement and added this pillar, I think it was about 5-10 years ago, I had some interesting conversations with some industrial organizational psychologists who were like, what'd you think? Healthcare, you think you could have done the other 3 without that? And the IHI knew that. Part of what the IHI and others in the field talked about when this 4th pillar was added was they had to call it out, because the organizations who were achieving healthy populations, enhancing the patient experience, reducing per capita cost, had already learned what, if you remember Delta Song, Southwest Airlines, which so many other thriving businesses had learned, which is you have to pay attention to that joy piece if you're going to achieve that degree of customer satisfaction. And I call that Delta Song, not Delta. Those of you who remember Delta Song, it really was a customer-centric approach, and they valued their staff. IHI recognized they had to call this out as a 4th pillar because there were enough organizations in healthcare who were missing it. And as a result, they were not achieving their first 3 pieces. It's also not a new thing. And the idea of physician burnout is not a new thing. So this was an article in 2004 in the New England Journal of Medicine on physician dissatisfaction. Right? Is the profound unease within the medical profession today historical aberration? Most evidence suggests that it is not. Rather, it's the golden age of medicine in the mid-20th century that was the oddity. The article goes on to talk about the fact that career satisfaction, professional satisfaction for physicians by the time that this article was written had fallen to the degree of attorneys and other professions. It had been higher before. Now they were all tied. But 30 years before, medical professionals were actually low again. And one of my first professional mentors, the medical director at Bellevue Hospital in the late 90s, had said the whole idea of the golden age of medicine really was that physicians were being paid really well. Were being told that everything they did was good. They could go to work every day wanting to care for their patients, wanting to help people, being paid well, and truly believing that whatever they were doing was a good thing, because this was before we were really assessing quality of care on a grand scale, certainly before we had the EHR-based data to get a real broad scale of how well we were or were not doing with our patients. No one was grading us or criticizing. And so we could all believe we were doing the right thing, most of which, people were right to believe, but that even included the orthopedic surgeons doing arthroscopic knee surgery and the 65-year-olds with arthritis and the ultrasound scanners to screen for osteoporosis. Before we had the data that it didn't help, right? We now have the data on where those things don't help. And we're now giving providers a lot of negative feedback, important negative feedback about what we should be doing with our patients, what we should not be doing with our patients. But that's a sea change. And obviously, a lot of providers have also faced changes financially. These are big changes. And then we add all these EHR pieces. So is burnout worse? The numbers say it is. The applications to medical school raise some questions because In some ways, in many ways, it's more competitive than ever. But I just want to raise the notion that the I hate the EHR, it became an easy target because it also required people to learn a new skill. Now, I'm not going to praise most EHR implementations. Unfortunately, most are not good in the country. The issues, we know how to fix many of them before I go to other resources. So how can organizations navigate their ways through this? In part, it's by using what we've learned over the last 10 years. Even the vendors for these EHRs have learned. First of all, we've got to make sure that these are physician and nurse and clinician-led endeavors, right? We have to stop putting technical experts in charge of the decisions for how we use these technologies in our care of patients. As simple as how we order medications, how we order vaccines. And now the problem with that is, as Wright and Hirsch, or Hirsch and Wright, pointed out over 10 years ago, we don't have enough skilled people to make those decisions at enough organizations, and that's a problem. But that may also require some of the organizations to slow down their pace, or at least be realistic in their expectations. Because, you know, as the Einstein quote is, if you tell a fish it's stupid for not being able to climb a tree, if you tell a fish to climb a tree, it'll die thinking it's stupid. That one took a couple tries. Or if you tell someone who's 5 feet tall to grab something off the 10-foot shelf and you don't give them a ladder, none of these folk or fish are going to feel very good. And so part of what we need to change the perspective on these EHRs, and this is this whole idea of social informatics, is that these are management organizational efforts that need to be realistic and need to understand what's going on in the trenches of healthcare, in the patient provider and provider care team interactions. And we need to not see our physician resources as unlimited, because we need to understand that if we continue to ask our providers to just click away, they're going to not be able to do a good job taking care of their patients. And there are organizations who have learned these. One of the constant complaints and criticisms that I hear about EHRs is it's 10 clicks to prescribe a vaccine. Yeah, as Peter Bash down at MedStar has been saying for years, why are physicians ordering vaccines? This should be a protocol order. But in order to understand that a vaccine can be a standing protocol order, so the nurse can actually just administer it to a patient without even needing to check in with the physician, not 100% of the time, but the bulk of the time, you need to actually have a clinician overseeing that process. You need to have someone who understands the technology to make sure the technology can work for that. And that may even require some reconfiguring of the EHRs. The good news is actually the vendors have gotten better about this too. A year and a half ago at the AMIA conference in 2019, there was actually a vendor of panels presenting on their new approach to doing optimization at their own customers, which is actually going back to customers with existing installs and helping them change these kinds of workflows. So the good news is these things can be done. 15 years ago, we all thought we had a better idea how to do these things than the vendors, and many of us were probably right. But at this point, the vendors can be helpful. But again, someone needs to make the decision. And part of the problem is that this all costs money and effort. And also the recognition that we may need to change some of the power dynamic in these healthcare organizations, even at the vendors who are developing systems. $32 billion to roll this out. Again, based on what it costs to do it for 1,500 to 2,000 doctors in 3 small communities in Massachusetts, may not have been enough. You know, most industries are spending 8 to 10% of their operating expense on IT. E-industries, finance and energy are closer to 15 to 20% or even more. Healthcare is in the 5 to 8%, and when you start to get to small practices, and small, I mean anything under 100 providers, it's often down to 2%. That may take some change. We may not be able to get there from here with that degree of spend. We're also going to have to start to bring some innovation back to the technologies. And a lot of that is going to, by that I mean, is going to require them to be modernized. If you look at an EHR and you show an EHR to someone has expertise in UX, in user design, and the user experience, who's worked in other industries, they're usually appalled, because we're still working off grids and we're not using colors and shapes and parts of the screen the way we should be if we want to make the safest, most effective, efficient interaction for our nurses and our doctors, and ultimately for our patients, to achieve quality care, if we're going to try and do that with these tools. What that means is there's a lot of expertise in other industries that we could bring in, but that also is going to require some flexibility in our EHRs. That's where a lot of apps, standards, and I think also making the data available to patients is going to drive this. Because once we start making data available to patients, which is now at least mandated by federal law and will soon become common practice, we're going to create opportunities for people to come up with new applications, new ways of looking at data, and enter the market and probably disrupt some of these larger vendors and larger systems that are in place. But it's going to take time, and it's going to take more change. And it's probably going to require that we allow some failures in the meantime, so that we can continue to learn. I'm also going to shout out, there's a wealth of knowledge out there, professional societies, academic, and others, that when we look at the problems that are going on at the sites that are struggling, and we look at what people in any of these other organizations are doing well in similar scenarios, and by doing well, I mean not running into the same problems, the answers are there. And the unfortunate piece is we keep seeing, again, the repetition of failures. There was a discussion about data sharing that AMDA supported about a week ago, where people were talking about the problems with making pediatric data and adolescent pediatric data available, and issues of confidentiality, and how that causes a problem for a parent with a child with special needs, because if the child ages into the area where there are new confidentiality regulations and you've been managing their care that they need, all of a sudden you can't get access to data. And this was at a very large, world-renowned healthcare organization. That exact scenario actually was a HIMSS chapter on it, I think in the second edition, and other organizations that were already aware of it and came up with ways to overcome. So whether it's how to deploy your effective wireless device, whether it's to stop resetting your passwords, whether it's to create your order sets to make better workflows, whether it's to change your access, whether it's to reconfigure your screens or to staff things differently, so providers aren't spending their time clicking and signing forms. We have lots of ways around these things. We just need the organizational muster to take it on. Neil, I'm going to pause for a second. I'm not sure what you're seeing in the chat.
Yeah, so we have one question, which is, I'll summarize as, it's the best of times and it's the worst of times. The question is about transitioning, upgrading to a new EHR system. A lot of times data are missing in the new EHR system. And then at the same time, excellent EHR systems have lots of extra information, redundant information. So how do we handle that sort of tension between missing data and too much data?
And I'm going to add an and to it, another piece of complexity. Usually places that are migrating off of one EHR platform to another are doing because they had problems with the former. Sometimes it may be because of a merger and acquisition and a replacement, but often it's because their needs were not met. And usually when that was the case, there were huge amounts of workarounds that left all kinds of bad data in the EHR. So we can't necessarily just extract. You know, what we used to say even 10 years ago, when there were a lot more replacements because of the EHR, I mean, if we use that came out, there was the notion that we're going to have some redundancy of systems for people to be looking things up. Now, interestingly, what anecdotally has been repeated sort of year in, year out is usually after 3 years, The data is not needed as often. The oncology folk and the infectious disease folk are often the ones. There are subsets that may need data from 5, 10, 15 years out. So there is a recognized cost to make sure that you continue access to your old data. And there also is a recognized effort to extract information from an existing system into a new system. The important thing is to be transparent with your organization about the decisions you're making and why you're making them. And transparency probably means requiring buy-in organizationally, making sure you get that. In other words, requiring that the organization achieve some buy-in, which means involving in the decision-making your providers. You know, Stamford, Connecticut main hospital about, I don't know, 15 to 20 years ago, the providers hated their Meditech system. They did a big RFP. They looked at some of the newer systems. The leadership went on a talking campaign with the providers, talking about what the cost of replacing the system was going to be. And ultimately, as the medical community agreed, it wasn't worth the investment. They were going to hold off. I'm not sure what they ended up doing system-wise now, but my point is they got to a decision that was a shared decision. It's the same as telling your docs you need to wash your hands before you go to the ER, right? We recognize it takes time. We put together a process to make sure it works. So if we're going to upgrade the EHR, we need to recognize that if we're not going to extract all the pieces of the medical history, there are going to be some problems. There may even be some errors and adverse events. If we are going to extract the history, there's going to be a lot of work involved. And that's got to be a little bit of a shared decision. And part of what makes it difficult in the US is most of these docs are not employed by the hospitals. And usually it's not even a Kaiser Permanente scenario. We've got one medical group and one health system, right? You've got 100 or 1,000 different independent physician groups. And that just makes these decisions that much harder to make. It doesn't lessen the importance. And that's the important thing to remember. It doesn't lessen the importance.
Yeah, another question, which gets back to fundamentals of informatics. And so informatics, oftentimes we think about informatics as a technological intervention, but informatics is so much more than that. And so this question is, are there any studies where we've seen demonstrable evidence that the EHR is actually improving efficiency compared to the days of yore where we used paper?
I mean, that's the question we've all been asking for as long as I've been working in this field, and I think all of us have been. And part of the problem is that there are so many confounding variables. It is almost impossible to really assess that. However, obviously, folk have tried, and we should. And the outcomes are mixed. The data is very mixed. There have been a lot of studies showing that there's no benefit. There's been a lot of studies certainly showing harm. And there have been studies that have shown benefit. I think part of what we need to recognize is that it would be impossible across our health system in general to manage a complex scenario like healthcare without computerized data. The question is, how much do we need based on how much benefit, and how do we get there? And that even gets back to one of the questions of how much granular data do we need to be entering into an EHR to be running a quality report, right? We need to capture the data we need to measure. But if we don't need to measure the data, why not just make it easier for the physician or the nurse to enter the data? Before we implement EHRs, so many physicians on their physical exam on a paper note would just write WNL for the entire body. We don't see that as much in the EHR. Maybe having a single click that was WNL is just as good for a lot of scenarios. Doesn't mean that the cardiologist who wants to follow an exam or someone else who wants to follow an exam, it might not be worthwhile documenting, or the dermatologist who at this point is probably using a photograph anyway. But the point is that there are extremes. And the important thing is that we identify, what are we trying to achieve? Is the goal making sure that we save our money on staff and have the physicians do everything? Is the goal making sure that the physicians see as many patients a day? Is the goal making sure that everyone who needs a vaccine gets it, or everyone who gets radiation therapy gets the right dose and doesn't get a higher dose? These are the scenarios that should be driving what we measure. when one of the things that is often looked at in meaningful use in a hateful way is the fact that smoking monitoring has to be clicked and stored. We have to identify to our patients smoke. We have to say if we're giving them treatment. So some of the history of that one is that when Bloomberg was elected mayor of New York City, he invited Tom Frieden to come back to be the commissioner of health. Dr. Frieden was off in India eradicating tuberculosis, and he agreed to come back to New York to be the commissioner of health if Bloomberg would make anti-smoking a cornerstone of his administration. The rest is history, right? We all know that Dr. Frieden's campaign and the New York City-wide campaign, which Bloomberg talked about all the time until vaping came out, had dramatically reduced smoking. Part of how we did that was bringing into healthcare. So Dr. Frieden, as Commissioner of Health Chair, was on the board of directors in New York City's public hospital system. He chaired the subcommittee on quality, and his question to his epidemiology director, Farsa Moschari, and me as the CMIO of New York City Health and Hospitals is, I want to know how many patients who go to New York City Health and Hospitals smoke, and I want to know what you're doing about it. So we said, all right, this is important. Our head of quality said this is important. We've got to track this and we've got to treat it. So we built the EHR tools for what was important. Some folks wanted to do Wi-Fi programs running through the hospital. We said, no, our head of quality said we've got to focus on tobacco. So we built the tools to capture the data. We built the tools to support our treatment programs. And then using those same tools, we could run the analytics. That became part of meaningful use because Farsad and others, we all did learn that that was effective. Now, you have to do it in a way that is easy to take advantage of it. But the idea is that we should be measuring what's important. We should be building the tools to help us address what's important in healthcare. And if we do those things effectively, we should have the right cycle. But you can't do that effectively without having people on the team who understand technology and informatics and the healthcare.
Yeah, so we have a few more questions. So this is about the bad guys. And so all of us who work in healthcare, in the various parts of the healthcare ecosystem, have very positive goals in mind and how we want to use data for supporting care, for supporting the patients that our systems and services are designed to do. But what about the bad actors? Especially as we're talking about the availability and information blocking and how that now sort of opens floodgates for for-profit entities to come in where their alerts and the like may not necessarily be healthcare driven, but they're profit driven. Perhaps one of the most well-known cases is Practice Fusion taking kickbacks for clinical decision support for opioid prescriptions. And so how does that impact clinician trust in these EHRs and I guess, generally health IT?
I think it should keep those of us who are working on these systems very humble because as you said, everything is a double-edged sword. In fact, it doesn't even need to be egregious and malicious intent. Jonathan Teich, who gave a talk a couple weeks ago, had a great paper, 15, 20 years ago, that showed an antibiotic list. If you altered it and listed the antibiotics alphabetically, the top choices, the A's, were the most chosen antibiotics. If you got rid of the alphabetical listing and ranked the medications differently, people again ordered from the top. So there's a user interface component, which makes sense now that we understand the user design, that actually causes outcome. So we have to be humble and recognize that there can be secondary outcomes, not always good ones, because amoxicillin may not have been the right antibiotic. And people may have been choosing it because they listed alphabetically on top. And so we need to pay attention to our data and our quality. And the example that you mentioned, obviously, that's more egregious, more malicious intent and criminal. But obviously, we need to be paying attention and monitoring all of those scenarios, just like anything else in healthcare. But we need to pay attention to accidents also.
Yeah. Last question. So, what becomes sort of an inside joke for all of us who work in the industry, meaningful use, how meaningful was it? And so when the federal government starts to put requirements on local practices and the like, how do we better engage teams to make sure that some of those that may make sense, but also there's an individualization, a personalization to the specific healthcare workflow. How do we get more of that rather than it's because the federal government wants us to go onto the problem list and talk about smoking status? How do we, what are some of the key things that we should be thinking about?
So I think it's very difficult without having value-based contracts and value-based purchasing on a dominant scale for us to really incite the types of innovations that lead towards quality. Because we keep seeing that with all the experiments with healthcare IT and innovation that are linked towards efficiency and improvement. And we see that when we look at the different markets in the US. That doesn't mean that we can flip a switch and become a value-based purchasing country for healthcare. But I think that if we were to accelerate our value-based models, which may also require a coalescence of our payers. We may not be able to do this with multiple payers. We may need to have and it could even be a single dominant payer that has subcontractors. And we all know Medicare Advantage plans have created all sorts of good incentives that have actually done some good things. And it's in the US model, right? It's government outsources it to private entities. But I think until we start to, I think that the way to enable the local experimentation is to create the big target, is to include the financial responsibility across a long term. Not I'm covered today by Blue Cross Blue Shield Rhode Island because I'm employed in Providence, and who knows what's going to happen to me 15 years from now. So does Blue Cross Blue Shield of Rhode Island really have an incentive for me to keep things from happening healthcare-wise 15 years ago? Not on a commercial end. And financially, maybe it'll even cost them money. We've got to get rid of some of those pieces, and we keep seeing it comes down to value-based purchasing. The Atul Gawande's Big Medicine article where he talks about Cheesecake Factory, I think highlights this example well. You know, he then followed up with his article in the New Yorker just a couple of years ago on how much he hated the experience of implementing Epic. But he talks with the implementation about Epic about having a small monitor. He talks about having problems typing. He's clearly putting things as a surgeon that why are we asking a surgeon to be doing this type of manual data entry? So this is Atul Gawande at Partners, right? So if organizations like that who know how to do this better than most, and if people with agency and voice like him are still running into the same problems, it shows we've got to make it easier and we've got to do a better job not doing what doesn't work and helping people know how to avoid what doesn't work and helping people be aware of what does work and using it.
Well, thank you, Jonathan. This is a fabulous conversation, and your insights, I'm sure, and the conversation is just going to keep continuing. And thanks again for spending some time with us today, sharing your thoughts and insights, and we'll see what's next.
Thank you. I will also I remain optimistic on all of this. It's just going to be, how long is it going to take us to get to a spot that we're feeling better about it?